So thank you for, this is really loud. My career as a newscaster is doing, all right. Thank you for letting us come and talk about this issue. Jen and I've walked out. Can you hear me still? Okay. Jan and I, as well as colleagues from patient relations and patient resources at UW Health, security, pharmacy, behavioral health, have put this information together for everyone. And our goal with this presentation is threefold. One, we want to bring attention to the fact that there are ongoing issues with disruptive events that are continuing and probably are not going to go away for the healthcare industry. And the idea is, what can we do in response to keep people safe? And then, so part of what we want to do as well is to talk about, what are some of the signs that you should look for, risk factors of an event that could become disruptive, so that you can plan proactively to set things up to prevent those from getting kicked out of the way. Oh, perfect, thanks. So that you can plan to proactively to prevent something from becoming that way, setting things up to decrease the likelihood of becoming disruptive, or if it does, you have resources in place to step in and to assist. And really from the faculty, from the physician perspective, you may not always see the disruptive events as much. This may be more, when nursing or frontline staff may see the true bad behaviors and people may behave a little bit better when the physician comes in the room. So we want you also to be kind of aware of the risk factors so that when staff indicate things to you, or when you see something just from your own knowledge of the situation, that you can step in and support efforts to be proactive in planning for these potential events before they occur. So we'll talk a little bit about those risk factors. Why are disruptive events continuing and escalating in some situations in the healthcare field? What are the signs, the risk factors that you can look for to clue you in that this may be a situation that could develop into a disruptive event, and so you can plan ahead? We want to also bring some practical tips. So if you end up in a situation where the conversation is escalating, where it is quickly moving towards something that raises a safety concern, what are some practical things you can do to try to stop that from spiraling out of control, or at least to protect yourself and leave the conversation in a safe way? And then we'll talk a little bit about some of the resources, some of the planning that we can do, and how we can assist in trying to get ahead of an event before it occurs. So violence in healthcare, if you look at the statistics up through 2013, for example, show that in all private industries, injuries to healthcare workers, injuries by another person to someone is 4 times more likely in the healthcare field than all other fields. Very small ears. There you go. And if you look at just the numbers, in terms of when those things happen, who's causing it? It's by and large due to patient actions, and then the second largest would be clients or the customers, essentially the family or the, am I really looking goofy? Is that what it is? What's that? Oh, student, oh yeah. Oh yeah. Thanks for warning me, guys. I'll keep back. All right. So by and large, it's from patients or families that when somebody causes violence, that's the primary source. Where are these most likely to occur? It's in those situations of close contact and high emotions. So when those things come together, emergency departments, behavioral health, medical units, particularly in situations with patients who are in a state where they're not able to self-restrain as well, detox, for example, dementia. IMC and ICU units, there it's less the patient than the families and visitors who may be in higher emotional states at that point. Waiting rooms, when patients are in pain, when they need to get care and they don't seem to be getting the services that they're expecting. Detox, as I mentioned. But the bottom line is these things can happen anywhere. So you need to, you want to be sensitive to potential issues, even if you're in your office or in a setting where there are a lot of people around. When, what times, and what situations are they most likely to occur? Again, in times of increased stress. So when a patient is experiencing an emotional event, they're hearing bad news, or they're not going to get the treatment that they expected. Denial of services, particularly we see this around opioids, of course. There are more and more people who are expecting, wanting, and very argumentative when those prescriptions are not given. Times when there's an involuntary treatment or admission, so when somebody's being restrained or subdued, particularly in the emergency room, for example. Enforcement of limits, so telling someone that they can't do something, they can't go somewhere, they're not being able to get something they're expecting or demanding. That could be a situation that escalates. And then access issues, when patients are expecting, needing to get a service and they're not getting it fast enough, or that something's been canceled, or they have a long waiting time. Those are all situations that could start someone escalating their behaviors. Times of increased patient contact activity, that is when you're in and close to the patient. So when cares are being provided during the triage setting where the patient really isn't familiar with you yet, wasn't familiar with the situation yet, has less self-restraint perhaps than they will once they get acclimated, and of course times of emergency. Another time is when there's decreased visibility. So essentially, we are wired that we tend to behave better when we expect a lot of people to be watching us. I'm behaving very well, for example. You're all watching me. But if there are times when we're more anonymous, where we just have that natural tendency to not restrain ourselves as much. And so people who are angry, upset, when there are a lot of people around, they will still have that natural tendency to keep in line. But if they feel there are other people not there, so it's night times, for example, times where you may be in an isolated setting, in stairwells, elevators, parking lots, or exam rooms, patient rooms, where they know someone's not going to be walking in or walking by as frequently. There's that less of a need to restrain oneself, and so a greater chance that those emotions may get away from them. But again, these are just some of the situations where they are more likely. They can occur at any time, and you have to kind of be sensitive to that. So why is it worse in healthcare than in the other industries? Well, one of the problems is that these sorts of behaviors are not always recognized for what they are. So when I was in private practice, if someone came into the law office and they started pacing around and yelling and pounding on the wall and making threats, we'd say, well, the plaintiff's attorney is here. But that would stand out. Okay, that's not usual. People would take that very seriously. I think we would react in a pretty significant way. But in a healthcare setting, there's a lot of that. There are a lot of people who are acting in ways that show them being upset or agitated. A lot of high emotions. And so this sometimes just kind of blends into the background, and people don't see that as a warning sign of something more that could come. Again, in the healthcare setting where you're dealing with situations of high emotion, people in pain, people worrying about their future, the future of their loved ones, people dealing with a lot of guilt, perhaps, about the condition of their parents and what's going to happen next. All those things come up more frequently in the healthcare setting than in many other industries. Situations affecting self-restraint. So patients who are suffering some condition or illness that prevents them from restraining themselves, more frequently seen than in the healthcare setting, of course. Some of the traditional views, too, I think, can get in the way of acting and pre-planning. The idea that it's just part of the job to take this. The people I've worked with, they've been hit before. You get hit, you just deal with it, you move on, you take care of the patient. It's not the patient's fault. I don't want to I shouldn't be blaming them for this. They're ill. Those things are true in a sense, but what we want you to recognize is recognizing a situation as something that could become dangerous and planning for that is not punishing the patient. It's not saying they're bad. It's not saying that they're should be punished in some way. It's just saying this is something that we should look at and potentially plan for. Sometimes there's an assumption that HIPAA won't allow providers to discuss patient concerns with security, and that's not the case. So if you have a concern, you can reach out to risk, legal, patient relations, patient resources, security. All of us are under that same legal umbrella, and you can talk to us about those sensitive, confidential information so that we can help plan with you and answer your questions. And then there's a reluctance sometimes to report these incidents. So at UW Health, we have the PSN system for incident reports, and we see some behavioral incidents in there, but certainly not at the frequency that they're actually occurring. And again, I think it's the idea that putting in a PSN is somehow punishing someone, or it isn't going to actually impact a situation that's already passed. But I can tell you that what we look at and what the hospital system does with those PSNs is we look at that data and we say, are there areas where this is happening, where people are potentially at risk? And are we doing enough to support them there? Do we have the resources that they need? Are we giving them the time in terms of educating about what to do? So those incident reports really do help us and help the system direct attention and resources to help prevent those things from happening. So, it's not the immediate thing, you get security that you react in the moment that way, but once something has happened, it is very helpful for us and for everyone in the long term if we can get an incident report filed about that. All right, so let's talk a little bit some of the warning signs and risk factors to look for that could clue you in that this is something that may escalate, that may become worse. We'll look at it in terms of someone's history, someone's current conduct that you might observe, and then how they're communicating. So in terms of history, past behavior is a good indicator of future behavior. Someone who has a history of disruptive conduct, particularly in a healthcare setting, that's a red flag that they may do that again. History of violence. Someone who has access to or possession of a weapon. No, it's not that we're saying that someone who has a gun that owning a gun makes you more violent, obviously. Rather, it's if there's someone who has that potential of becoming violent, acting out, losing control of their emotions, and they are also known to have a weapon on them, that's a potentially bigger risk, of course. So that's something to keep in mind. Someone who has undergone a significant medical event, had a bad outcome, has heard some bad news that they weren't expecting. Someone coming up on a significant date or anniversary. So sometimes we see patterns of people coming out of nowhere, year, 2, 3 later, and looking back, it turns out that that's the anniversary of their wife's death, or when they lost their son, or when they heard the diagnosis about their daughter. So those periods can come up and sort of trigger all those emotions again, even after a long period of not hearing from them. The next couple of factors really relate to people, who don't act the way we would expect in the sense of adhering to normal social rules, right? So someone who shows up at the facility at odd hours, and then once they're told, we're not open now, or we can't stay open at this time, but they keep doing that and they keep insisting on it, and they can't seem to get away from that, that is a red flag that something might escalate. Similarly, if they access restricted areas, they go into a room, they wait someplace that they're not supposed to, again, after they've been told, and instructed, and yet they continue to do that, that should be a red flag that this is not someone who's going to follow the normal rules of behavior that we can expect. That should be a red flag. And then those attempts to cross relational boundaries, wanting to call you at odd hours, wanting to email you, text you, all those things that kind of go beyond that normal physician-patient relationship. Again, that doesn't mean that initially that is a sign of a violent person, but when you tell them I can't do that or this is not appropriate, and yet they persist, again, that should be a sign. One of the kind of dilemmas in healthcare is that you have this dual, not entirely consistent set of expectations. So if you go in and buy a car, right, you're the customer, and you can expect what a customer expects from the car salesman. When you're a patient, well, you're a customer in a sense, and certainly in the media that idea is put forward. But there's also, that's a different set of expectations as well, because it's not that you can demand anything. You're going to someone for judgment, you're going to someone for advice and experience, which is a little different than all the other customer situations there. And sometimes that is a real cause of confusion for people. They expect you should be doing what I ask, because when I go to buy a car, they do what I ask. So that relational boundary piece can be very important sometimes to kind of draw those lines for people when that customer-patient relationship is confused for them. Looking at some of the signs of current conduct that might be a sign for you. So again, someone taking on an aggressive or hostile posture or attitude. Someone who gives repeated signs of discontent, irritation, frustration. And again, you should want patients, families, if they're upset, concerned about something, to tell you, but it's those situations where they can't get away from that, where they tell you, you answer, you give them a plan, yet they keep coming back to it. It seems to take over everything and every subject and be the center of everything. Those are the signs that this is a situation that could potentially get worse. Someone who is having changes, particularly rapid changes in terms of their volume of their speech, or the patterns of their speech, how fast or slowly they're talking, rapid pacing, excessive fidgeting, all those signs that show you that something is bothering them, and they're trying to figure out how to react to that. When you see defensive body language, someone is huddling in, muscles tense, kind of is trying to withdraw from the situation. Or the reverse, someone who is being very aggressive, very in your face, moving forward a lot, very animated motions, potentially violent motions, hitting things. Obviously, as we get more extreme, the more obvious, but keep in mind it's a spectrum. So when you see those changes, particularly changes in a short period of time, or changes that don't seem to connect with the current discussion, that should be a red flag for you, that this may get worse. Someone who invades personal space, touching, pushing, of course, or again, a patient who has exhibited bizarre or impulsive behaviors. It's not being inappropriate to recognize that even with a medical condition, it's not their fault, but it's still something you need to recognize and plan for, that there may be a physical risk.
Can I just add one thing, Bob? Can you hear me through this? Is it working? Okay. So one thing to point out about the conduct piece is that I think our staff struggle with is when a patient has been agitated and they've been pacing or they've been showing behavior, and then they get really quiet. And they go, oh, finally it's quiet. Sometimes that's a big flag that something big is going to come. So we always say, don't get too comfortable with that. Really watch to see what's going on, because that's when you're kind of taken by surprise, because you kind of relax and you're not necessarily as vigilant or on guard as maybe you should be. And we've seen a fair amount of that. So that's just another sign that even though they've been agitated, now they're quiet, and it may be that you've medicated them, and that makes sense, but sometimes it's just, they'll just go right into a very quiet mode and then all of a sudden explode. So.
Yeah, it's that sudden change or that change that doesn't fit that you want to be sensitive to. So in terms of communication, certainly someone who's shouting, using profanity, aggressive speech patterns, talking over you, not letting you get a point out, expressions of anger, frustration, again, not that we don't want, in fact, we do want to hear those things from patients and families. It's when they persist, when they can't be redirected, when they seem to take over every part of the discussion, is when they become red flags. And and it's helpful to try to understand what the message is under that. Are they saying, I'm being deprived? When they make statements about my wife is dying and you're not doing anything to help her, why aren't you listening to me? Why aren't you doing this? What are they really saying is, I'm being deprived of something. So if you can address that underlying message, it's helpful to de-escalate something. But recognize that when those statements keep coming and take over everything and don't seem to be redirectable, you should have a heightened sense for where is this conversation going and what might happen with this particular person. Along the same lines, focusing on a past wrong, injustice, something where they feel that I was treated wrong here before, the last physician who saw me didn't do this right. Again, when it becomes sort of the center of everything, is when that's a sign that this person may escalate with you as well. And again, patients who won't follow directions or requests, unable to calm themselves, unable to restrain themselves as we would normally do and expect. Or patients who, for medical reasons, are experiencing things that affect their ability to control themselves. Delusions, paranoia. So the most frequent sign you will see in these situations when something escalates is that rapid increasing psychomotor agitation. But as Jan said, you also want to watch out for that sudden lack of movement and response. Both of those indicate that the situation can change suddenly and become physically violent. So what are some of the things you can do to stay safe during those events? And again, as I said at the start, what we want to do is talk about some of the risk factors and some of the early warning signs so that you can see these things in advance and plan for them as best you can. Because there are a lot of opportunities to prevent some of these situations we see looking backwards. And from the physician perspective, you do that by being aware of the risk factors we talked about. And even when you don't see them, again, because you may not have as long a contact or people may be behaving slightly better when you're there, if you're hearing that from staff, it's important to become involved at that point and support them, because sometimes staff feel like if they don't have the physician support, maybe they can't do something or they're not supposed to do something. So it's important to provide them that support, encourage them to find out, get more information from them. What are they seeing? Ask questions of them. What are they seeing really signs and symptoms of an underlying condition that could be treated with medication or should be addressed otherwise? And give them that permission to work with security or to work with you in security to plan for something that's worrying them. So if that all fails and you do find yourself in the midst of a situation that is escalating, what can you do? So first, be aware of your surroundings. Have that sort of in the moment assessment of where you're at and what's around you. Are you in a place where you're able, if you're in a room, are you able to get out of that room if you need to? Is something blocking your path to that exit? Or if you're in a room with someone who's beginning to escalate, are you in the way of them leaving if they need to? Because if they feel trapped or restrained in some way, they may act more emotionally than they would otherwise. So just making sure that they have a path to leave that room if they need be is important. Are you isolated? So are there people who can hear or see your interactions or what the patient or family member are doing? Again, in part because the presence of other people will tend to restrain others a little bit, but also that if something begins to happen, is there someone you can call out to, or is there someone who's going to be able to react and call for help while you're dealing with the person? Are there any potential weapons around that the person might use? Any personal belongings that they have, a purse or bag where you don't know what's in it? Do you have anything on you that could be used against you? Are there medical supplies or equipment that had been being used that are nearby? Desks, counters that could be swung around, IV poles, all of those things that could be potential weapons you should be at least aware of as you in the middle of this sort of escalating situation. Is there an alarm that you can make use of if you need to call for help? Are you able to shout and people would hear you if need be? And if not, if you're in a place where you're isolated and you really can't get help quickly, is there a way that you can move that conversation to a place where you can do? And our natural tendency in many of these situations when someone's escalating is to take them somewhere where that you can talk privately and try to quiet them down, which is helpful, which is good. But you also want to be aware that if you're too isolated, if you have no way of reaching out, that can be dangerous as well. So sometimes it's a balance between having a private discussion, but also having it near someplace where you can get help if need be. And then the lighting. Is it dark? Is it dim? Can people see you? Again, lighting goes to whether or not someone will also be more restrained, or do they feel that nobody can see what they're doing. Be aware of your body language. So, the more we can see all of each other's faces when we talk with each other, the more that we have that, the open body language that tells us that we're not shut off from you. The more that we can keep our verbal exchanges positive or at least collegial with them, the better. These things that you may not realize are negative really can strike someone who is not a physician as a real barrier between you. So think about that. Are they able to see and interact with you, or is your body language pushing them off? So try to keep a relaxed posture. Avoid things like clenching fists or pointing sharply, things that could be interpreted as a violent movement. You want to maintain an attentive expression that you're engaged with them. So be cognizant of your body language. Am I acting like I would with someone I'm just chatting with, or am I reacting to their emotion, and try to counter that as best you can. Be aware of any choking hazards that you might have on you. You have a lanyard. Most every lanyard now is one of those breakaway ones, but do you have one that isn't? Or do you have a necklace or a stethoscope that could be used? So anything that's on you that could be used against you, be aware of that. Try to position yourself as you talk with them at an angle. So because again, if you're standing right in front of them head on, that can be interpreted as an aggressive posture. Also, all your organs right there, whereas you're standing at a side, you're a little more protected that way as well. So standing at a side a little bit when someone's becoming aggressive with you is a good idea. Are you providing them sufficient personal space? Might be difficult sometimes in a small hospital room or a small clinic room, but as best you can, are you giving them that space so they don't feel that you're escalating the situation? Are you speaking with them at the same physical level? So if they're sitting, are you sitting? If they're standing, are you standing? When we talk to each other at the same physical level with each other, it's much easier to make that connection and feel that someone's trying to connect with you. If you're talking down to them or up to them, then that's just one other thing that isolates you from the situation and makes it harder to try to de-escalate. If you're a person that likes to touch someone and pat them on the shoulder to kind of connect, if someone is escalating, that's probably not a good idea. So resist that natural urge because they're not going to interpret it the appropriate or same way. And keep your movements calm, slow, and deliberate. That sounds obvious, but when you get in that emotional setting and someone gets angry or frustrated with you, it's easy and very natural for us to adopt that anger ourselves. And we don't even necessarily realize it. So just be aware of that and keep yourself in check and say, I'm not going to let their anger become my anger, because that creeps into all of your body language. Along the same lines, be aware of what you're saying to them. Speak slowly, quietly, confidently. Remain open-minded and objective. So even if this is a person who has done this many times before, if this is an issue you've already talked with them about and you're frustrated with them, even if you know exactly where this is going to go, try to keep that piece in check. Try to say, at least to yourself, I'm going to listen to this. Maybe there's something different here. Why? Because if we already assume the end, if we let ourselves go there, that translates into all of our body language, translates in terms of how we talk to each other in ways that are harder to catch. If you try to check yourself at the front end and say, I'm going to keep an open mind here, it helps with all those sort of subconscious things that come from how you view a situation. Keep your message simple. So someone who is angry and becoming angrier is not going to be able to necessarily unpack a very complicated, nuanced response to that. Keep it very simple and calm so you can start getting through to them and get a plan in place. Practice active listening. So you want to do those things where you're responsive in terms of both your verbal and your body language. So you want to be looking at them, you want to be responding like we would in a normal conversation, mirroring, so sometimes repeating what they're doing, asking questions, summarizing, asking them to go into some more detail, asking clarification questions, saying, I'm understanding you that you want this. Did I state that right? All those things that we do with each other when we want to connect with each other, and we're trying to make that connection. Focus on those. Don't lose track of those. And it's hard, and I experience it too when I'm talking with someone, and I hate writing because I can never read my writing later. So I try to type all my notes. But it's really uncomfortable to do that because I always feel like people think I'm checking my emails while I'm talking to them. So it's that you have to chart in the record, but that sometimes could be misinterpreted. So all you have to say is, you know what? I'm just charting. I'm listening to you. Don't worry. I'm hearing what you're saying. So recognize that if you're not looking at them, that may be taken as you're not paying attention. But if you just explain that to them, people understand it. And that fact that you're reaching out to tell them, that connects with them as well. So those simple things to show people that you're actively listening and involved in hearing what they're saying, those are very important. And we find not infrequently just having that chance to vent, hearing all of it once it gets out, then the situation kind of de-escalates itself. People just want to be heard oftentimes. So give them that chance and let them know that you are hearing them. What were you going to say?
Yeah, I just wanted to add. One of the things I wanted to add about that we see, because we're just from our experience, is that people also tend to avoid. So they spend as little time with a patient as possible, and this is especially on the inpatient because you're with them 24/7. So patients tend to, sometimes that's not a good thing. I mean, sometimes you have to walk out of the room and say, when you calm down, I'll be back to talk with you. But there are times when we then tend to avoid as much as possible. And then they escalate because they're not getting the attention that they think they need. So it's kind of finding that balance, especially when you're with somebody for a stretch of time. And again, I say this on the inpatient because that's a lot of what I'm dealing with on a daily basis, but we have to kind of find that balance and not completely avoid them either, even though it's our instinct to say, I don't want to deal with that anymore. It's really hard. We still have to find that balance.
Along the same lines, one of the technique of asking, reflective questioning, so those open-ended questions, that can really help de-escalate a situation too. It's really bringing the questions back to them, asking them, can you tell me why is this important to you? Help me understand. So ask them to give you that information. Ask them to connect things for you. I know this is really bothering you, but we're here for this. Can you tell me why this is a problem for you so I can help deal with that? Ask them to help plan with you. Ask for that plan. What is it you want us to do? What would make this better? And that's particularly important if you're in a situation that's been escalating and you feel the need, I've got to get out of here because I've got to get help. But how do you break off from that? Find some type of simple solution that involves you going out with them, leaving the room, but cloaked in a way that you're doing something that they ask for. So I hear you that you're not getting a good response in your bills. If I go with you right now, we're going to go out to the nurse's station. I'm going to call the billing department and make sure that they're talking to you. Would that be helpful for you? So find some way that you're planning with them so that you can get out of that room instead of just trying to leave, because that in itself could trigger action. And then allow for silence. So this isn't the avoiding piece, but when somebody's escalating and then suddenly they've stopped, again, that can be, if it's sort of extreme and persistent, a sign that it's getting worse. But if somebody's just pausing, that means they could be thinking about it. And if they're thinking about it, then they're thinking about what they should and shouldn't do. And if they're thinking about that, then they're already on the path to restraining themselves. So just because there's silence doesn't mean there's a problem. And let them. Don't feel like you have to speak. Don't feel like there's always has to be something going on. Give them that time to reflect. But if it's that real different change, and you see it not just in lack of speaking, but in their body language and their emotion in terms of where their facial expression, all of that, that's a different animal in itself. But some silence is appropriate, and allow that. So one of the team came up with this helpful acronym, I think. So non-judgmental, undivided attention, reflective statements, silence, empathically listen for the real message. These are just some of the practical tips if you find yourself in that situation, how you can help de-escalate and get to someplace safe if need be. All right, so Jan, I'm going to talk a little bit some of the resources we have. And again, one of the big messages and takeaways we want is, we talked about all the risk factors and signs and things to look for, but what we really want to start doing is identifying these in advance and planning and proactively acting out so that we can prevent, or at least if it happens, we stay safer.
So one of the things that we did about 5 years ago is we came together as a group because we started to see behaviors that were escalating and resulting in harm to staff. So we felt like we needed to pull a group together, and patient relations is one of the key players in all of this. But we pulled a group together of stakeholders, and we worked to develop some tools that we thought would be helpful for staff to use. And some of them are ways to communicate with each other and to also call out what are the things that you're seeing, the behaviors that you're seeing with patients, and then what are the things that trigger those behaviors, and then what are the interventions that you can use to manage that behavior. So we pulled the group together. Security was very involved as well, but also frontline staff, because we wanted to get their feedback and figure out what it is that they needed as well. And some of the resources that you see here are, things that you have available. But when you have a situation with a patient, the process is that you contact patient relations, and they will pull a group together if need be to look at how we can better manage the behavior and put together a behavioral management plan. So we have different levels that we deal with. We have a kind of a low, moderate risk behavior plan, and that will have an FYI in the chart. Are you familiar with the FYIs on the left-hand column of the record? And those things are meant to be for your information, and they're very good tools. Not everybody appreciates the value that they have, but in there you'll see if there's a patient relations alert, you'll know then that there's something that maybe you should read when you see that patient if you're not familiar with them. We also have what we call our behavior safety banner, and that's a red flag that goes across the screen. That can only be seen on the inpatient side right now, but our goal is to work toward getting something very similar on the ambulatory side. But what it does is it alerts you to very high-risk behaviors where patients have actually either they are a threat to others or they are a threat to themselves. So even patients that self-harm, we have people that drink Purell. We have people that are constantly trying to harm themselves, and we want to be able to flag that because they're not always, they may have psychiatric issues and they may end up on B65 in the hospital, but not always. Oftentimes they come in for medical issues. So we need to communicate that across the system. And that flag is meant to alert you again to a behavioral plan. It'll point you to a behavioral plan that's been established. So what we call that process when we pull together a team to look at developing a plan is called disruptive event consultation. And there may be a point where you may be involved in one. We haven't typically had to do those types of plans for OB-GYN patients, but we do a lot of it on our medical patients, and sometimes on surgical patients that come in either as traumas and then develop some real behavioral issues. So we want people to know that those tools are there for you and those resources are there for you. So never hesitate to call to talk through things with patient relations. They're your front line for patient concerns. They'll loop in the people that need to be there, and if we need to put a behavioral plan together, we can do that. So we also have flags in the chart on the inpatient side called aggression precautions, and that's an order that either you or the nurses can put in to actually talk about what are the behaviors we're seeing. Here are some of the interventions you can do. And sometimes it's you don't go in and give cares without two people. It's really, very effective for the frontline staff so they know if it's someone that's from an auxiliary department like PT, OT, they can see that as well. We also have signs on the door. They don't say aggression precautions, but they'll say, please stop, do not go in the room before you talk to somebody. So we don't try to label our patients, but we certainly want to flag staff that aren't as familiar with patients that are coming to either consult or might have a one-time visit. The other thing we have is our Bert. You may have all heard the Bert called. It's a behavioral emergency response team that comes, and that is another tool that we can use. So when there is a very escalated reaction by patients and they feel like we can't manage this, they can call a Bert. And security, someone from B65, the psychiatry unit, our nurse coordinators will come and they will respond to that and assist the staff in managing that and get it in control and then determine what the next steps are. So you have a number of tools that you can use. I know I realize a lot of this on the inpatient setting, but even in the ambulatory world, we get patient relations get calls all the time to help manage a patient in the ambulatory setting, and then we can plan for their next visits. We can set up a plan if security needs to be there, whether they need to be in site or if they just need to be available. We can make plans for that, and then we know that when they're making appointments to make those arrangements. And we have that. Yeah.
Thank you very much for coming. This is a very important topic, and those of you that know me know I obsess about this stuff. So another thing I want to point out is this is important to Heidi yesterday, but also to everybody else in the clinic, because if something happens, that person will take out more than one person. Everybody should have got an email within the last month from UW about active shooters and stuff like that. It is totally different than what we were all trained about hide in place. Things have changed. You should go back, pick that out of your spam or your junk, and watch that, because it is very important 4%, I mean, a fourfold increase of risk. I've had this happen in my clinic. I've had an escaped convict knocked out a sheriff's deputy and came into my medical building, and we had the SWAT team and everything. I had to tell my patients, please come away from the door, and I had a 15-blade scalpel. That was my defense. So you should be aware of stuff like this because we're at great risk for bad things happening to us. Oh yeah, I will win. So I think this is important. I'm very glad you guys came and talked about this, but we should also think, we could be an innocent bystander to somebody else's bad stuff happening in the trauma room, and you just happen to be walking by.
Yes,
So
absolutely.
Next question. Dr. Henry.
Unfortunately, these are rare face-to-face events. 10 times more often, we get really abusive patients on the phone.
Sure.
I'm just amazed at what patients will say to my nursing staff and reception staff. I think they would never say to me face-to-face. And then, unfortunately, those are usually patients that haven't even they've never seen us before. They're trying to make an appointment and they're ticked off for some reason. And it's a tough balance. We don't want to say, hey, no, this is unacceptable. You can't come here. But yet trying to stay safe. I don't know if there's a really good option for our folks on the phone to say, now look, you've crossed the boundary here. I have to hang up. Or what we can have our staff do. I tell my staff, you don't have to put up with that profanity on the phone to say, I can't continue this conversation and hang up and then call patient relations. But I don't know if there's a great phone answer to these issues.
I mean, I think it's what do you do on the phone? I mean, I think it's definitely a balance. I think you let people know, recognizing people can be upset and pain, all those things. Let people know that this is not appropriate. We need to talk in a certain way. And then if they don't correct, and if they persist, that's the big sign that this could be even a bigger problem. So I think it's more than appropriate to kind of give them some warning, politely, that I understand you're concerned about this, but we have to keep this very professional and calm. And then if they can persist, then that's the big red flag. And what you do with that depends on if they're a current patient, if they're coming in that day, if they're trying to establish care. And so it may be a decision between calling patient relations, calling security first, all those things. But having that, telling them we're not going to put up with this in a polite way, giving them that chance to self-correct, I think is the reasonable approach.